PD Hinduja Hospital at Mumbai. But she has been trying to integrate palliative care into pulmonology for the last 5-6 years, and uh, she's um, she's a uh, faculty for various sessions at Pallium India. She has also done her national fellowship in palliative medicine. Then she has lot of other awards and recognition. In addition, she is also a trustee of Pallium India. So I welcome Dr. Rajam, and it's over to you.
Thank you, Sunil, and thank you to Pallium for this opportunity. Can I first please have, you may keep the videos off eventually, but can I just have a look at all of you so that I know this is the session 6, so I just wanted to know what you expect from this talk, and then we can build on that. I'm going to start with a few case presentations. So I would like this to be an interactive session. If you all can during the course of the case presentation itself, let me know about what exactly do you want to hear about, then we can focus about on that, because it has to be practical, it has to be interactive, otherwise it is not interesting. And all of you have actually finished a day's work. It must be very boring to just listen to somebody non-stop. So please do let me know if there is something in particular that you all want to hear. So let me start with the case first. 1 minute. So this is a patient whom we have just discharged recently, about a month ago. Can you all see the screen?
Yes, ma'am.
Yeah. So please keep it interactive, otherwise it's very boring. So this was, I'll just give you the background. This was a 56-year-old male. He was single and he lived with two siblings of his who were differently abled. He had one more sister who was married and staying little bit close by. This person actually had a good job. I mean, he had a own business in the garment industry till the pandemic. And the pandemic actually brought his business to a complete standstill. So he had really no income. And he actually stays in a distant suburb of Bombay, almost 60-65 kilometers away from our hospital. So he was first seen by the pulmonologist in November 2022, being treated for multi-drug resistant tuberculosis. Okay. Now, what has happened is at that time, he had also started noticing MRC grade 2 breathlessness. And because his saturation was about 93, he was subjected to a CT scan, and that revealed a fibrosing interstitial lung disease and resolving alveolar opacities due to the tuberculosis. Now, my question to you, which is also put up on the screen, yeah, would you, as a pulmonologist or a physician, or even a person who is sitting in, say, finished basic MBBS graduation, would you refer this patient to palliative care at all? And if so, why? Anybody?
Good evening, ma'am.
Yes.
Yes, we would. Yes, I would like to refer this patient since the patient has dyspnea. Palliative care starts right from diagnosis of any life-limiting or long-term illness.
Mhm.
And since he has a difficulty breathing dyspnea, we will definitely refer to this patient for palliative care.
So can I just extend that question to you, saying, would you only refer to palliative care because of breathlessness?
Mm. Among his symptoms,
What else
there's
is staring in the face for this patient?
saturation is low, but uh,
No. Two things are staring at your face.
The differently abled siblings.
That is one. That is a social aspect. I'm saying I'm still stuck at medical, but good point. So let me flip it the
I
other
was
way
sending
around.
to a pulmonologist also. He's got resolving TB, whether he's
Yes.
getting
And what
treatment for
TB
that
does he have?
pulmonary.
No, multi-drug resistant tuberculosis.
Uh,
So MDR-TB, please remember, though tuberculosis is an infectious disease, MDR-TB, extremely drug resistant, that is XDR-TB, totally drug resistant, that is TDR-TB, are extremely difficult forms of tuberculosis. So please remember, like we always say, palliative care is not based on diagnosis or prognosis, but very often infectious diseases, because we doctors are able to achieve cure, never ever come under the purview of palliative care. Having said that, tuberculosis, HIV, now in the recent experience, even the COVID pandemic, we realize how important it is to handhold these patients and caregivers, because how long is the treatment for MDR-TB? Anybody? Anybody knows the treatment duration for MDR-TB? How long is the duration for drug-sensitive TB?
6 to 9 months.
6 months. WHO recommends 6 months when it is drug-sensitive TB. Now, if it is multi-drug resistant TB, that means rifampicin is involved along with one or more drugs, in which case the treatment easily jumps up to 18 to 22 months. Imagine the patient has to take high doses of medications and suffer the consequences, and in some cases not even get a job because of the stigma, and till he turns sputum negative is not allowed to go to work because he's going to potentially spread drug resistant bacilli. So please, this all therefore contributes to the fact, and already poor fellow has lost his job or his business is collapsed. So therefore, please remember that TB as well as fibrosing ILD. What is the meaning of interstitial lung disease? Anybody? Anybody wants to answer?
It's a
What is
lifelong
it?
condition.
Sorry?
Lifelong condition.
What does lifelong condition mean? What is interstitial lung disease? Which part of the lung is affected?
Interstitium.
Which is the lung parenchyma, correct? Where is the interstitium in the lung?
It is in the lung parenchyma.
So it is,
Between
so basically the lung interstitium is the sieve of the lung, which actually helps in gas diffusion and perfusion. So once the alveoli have the air, the reason that it reaches the blood vessel is through the interstitium. So interstitial lung disease, the causes are innumerable, but what it leads to is that it leads to the fibrosis of the interstitium, therefore completely damaging the gas exchange in the lung. That's why patients feel breathless on exertion and patients desaturate on exercise. So it is unfortunately an incurable progressive disease. So what is the meaning of a lifelong disease? It is incurable and it is progressive. So actually some kinds of interstitial lung disease uh, is also actually compared to certain forms of incurable cancers. But we do not hear referrals for interstitial lung disease to palliative care despite the distressing symptoms that patients go through. Okay. So this patient, yes, should be referred early. All the more reason because he has MDR-TB and now diagnosed to have a interstitial lung disease. Okay. Once he finishes, let's go ahead with the case. Once he finishes his second line treatment, now he was under the impression that once my TB is cured, now I can do everything. I'll be fine. But he continues to get more and more breathless. And despite his sputum being negative and his X-ray clearing up for the alveolar opacities, his saturation continues to drop. And he's then started on the treatment for fibrosing interstitial lung disease, which is antifibrotics. After the COVID pandemic, are you all aware of what are the antifibrotics available in the market? Anybody?
Ma'am, is Parfenadone one?
Excellent. Perfenadone. And the second one? It's nintedanib. Okay. These are the two medications available in the market, which is given for patients with progressive fibrosing interstitial lung disease, irrespective of the cause, which is typically seen on a CT pattern. And the idea of giving them antifibrotics is to slow down the progression. So we are not able to reverse the fibrosis. We are not able to stop but evidence suggests that antifibrotics like pirfenidone and nintedanib can delay the progress of the fibrosis. Hence, it is important to give the patient a chance that his fibrosis can be halted. Okay. So now what happens is, despite all these things, his saturation continues to decrease, and now he's put on long-term oxygen therapy. Okay. So what is the meaning of long-term oxygen therapy? Anybody knows? Have you seen patients with oxygen, walking around with oxygen? Can you suggest certain other indications for long-term oxygen therapy? Yes. Okay, let me ask you a simpler question. How is oxygen given at home?
Oxygen concentrator and nasal cannula.
Excellent. What does an oxygen concentrator do?
Uses the room air and then increases the concentration. I mean,
So it
distillation.
takes the oxygen concentrator, takes the room air, which consists of nitrogen and oxygen, and only sends the oxygen filtered through the nasal cannula to the patient and releases the nitrogen, correct? It is an electric device at the size of a little suitcase. So it has to be plugged in under electricity, and you can get 5-liter machines and 10-liter machines. So typically we give oxygen to patients who are not able to maintain saturation between 88 and 92. Point number one. Two, when we subject these patients to a 6-minute walk test, where the patients are made to walk in their own pace for 6 minutes, we document the oxygen. What happens when you and I exercise? What happens to the respiratory rate?
Increases.
Increases. What happens to the heart rate?
Increases.
Right. What happens to the cardiac output?
Increases.
What happens to the oxygen saturation?
Normal.
It remains normal. It remains normal or increases. Because once you have a rapid cardiac output, a rapid increase in the heart rate, the muscles are utilizing the oxygen, the body actually responds by increasing the oxygen saturation, or it remains steady. What happens in patients with interstitial lung disease, advanced chronic COPDs, or those patients with a congestive cardiac failure? What happens to these patients?
Oxygen saturation decreases.
So there is desaturation on exercise. And that is one of the main indications to start these patients on oxygen. Please remember that oxygen is also a pharmacotherapeutic drug. You should not just give oxygen to all patients who are breathless. If you have given oxygen prescribed at home, you have to have a jolly well reason to give it. It has to be documented. You have to have done the 6-minute walk test, and you have to see that the patient desaturates on exercise. Any questions?
Can 6-minute walk test be applied to children?
So in children, again, I think they need to comprehend what you're trying to say. But in congenital heart diseases, etc., you probably can. I think kids need to be at least about the age of 6 or 7, where they are serious about and they understand what they do. But interstitial lung and chronic obstructive lung disease is very, very, very rare in children. Not that it's not seen, it is seen, but it's very uncommon. In which conditions would you want to do a 6-minute walk test in children, ma'am?
Madam, we have lot of congestive cardiac failure children. Those who are at home requiring and those who already have lung mets, children who have lung mets, they are also on home oxygen.
But lung metastatic children will not necessarily desaturate.
No, I have seen a child who has osteosarcoma with lung mets, and he was on home oxygen. he was desaturating despite oxygen at 5 liters.
So in
or
which
no.
case you don't need to do a 6-minute walk test, na? He was also clinically desaturating.
Okay.
See, when do you decide? You have to decide, you have to do test when there's a gray area, right? To confirm. Obvious desaturation even at rest is definitely meriting long-term oxygen therapy. You understand?
Yes, ma'am.
Correct? So
Yes,
suppose
ma'am.
now you have a patient who's got interstitial lung disease. He's breathless. He's desaturating. He's on long-term oxygen therapy. How do you think palliative care helps them? And what will you do when you refer to palliative care? And now that you are trained in palliative care, what all can you do for this patient? And especially this patient, please remember his social aspects and financial aspects also. So can you tell me what will you do for this patient? One by one, please. Can we start with Dr. Abraham? What
We
are
have
the
given
points you
pain
will?
meds, we've given steroids.
I'm not okay.
What
So you're talking from a pulmonologist perspective. I'm asking you a question of if he's referred to a palliative care physician, steroids is a treatment part that the pulmonologist will give.
you
What will
can
you
counsel
do?
him.
Sorry?
You can counsel him, tell him about the prognosis, tell him
So
what
what
he
will
can
you tell
expect.
him? Tell me what you will tell him. I am the patient.
ये दिक्कत जो आपको ये हो रही है वो तो अभी ठीक होने के लिए बहुत मुश्किल होगा। जो भी इलाज हम करते हैं उससे वो बिल्कुल ठीक से नहीं होगा। कभी कभी ऐसे होगा कि ये सांस की दिक्कत तो बढ़ नहीं जाएगा। अभी हम आपके साथ तो है, अब दवाई तो अभी शुरू कर दिया था, देख लूंगा कि फिर रास्ता कैसे आ जाएगा।
Okay.
जब ये इसकी फायदा तो नहीं होगा, फिर भी कुछ इलाज तो हो सकते हैं, ऐसे नहीं कि कुछ नहीं कर सकते। तकलीफ जो
So
हो रही है वो तुरंत कुछ
okay.
हेल्प
So
करने के लिए
now
दवाई
you
तो हम
have
चालू
started
करेंगे।
counseling him. Is there something you're forgetting to do before? What if I have read the full Google and come?
The
What is
patient is
Spike's
always welcome
protocol?
to ask any doubts whenever
What is the
they're
Spike's protocol? Do you
Setting
know
up
what
the
is the
contact,
Spike's? Yes.
and we have to test how much the patient wants to know. We
No,
have
before
to
that,
first setting up the
that
entire
is S. What is P?
perception, patient's
What does
perception.
that mean?
What does the patient know about the disease?
Exactly. You have to start where the patient stops, right?
Yes.
Very, very important to ask, what do you know about your illness? Then you can say that it is a damage of the interstitium. Interstitium is a sieve. It is something that will not be recovered. It is incurable. It is progressive. So then ask him, does he understand what it means? Say that we have medications to slow the progression, but not reverse the fibrosis. It means he will have a life limiting. It means his breathlessness will progress. All that Dr. Abraham said. But when you say ilaj, which means treatment, then you have to focus on what treatment, because in the patient's mind, it is treatment means cure. So you say, I do not have a cure for this, but I can keep you comfortable. I will focus on the quality of life. I will see that you're less distressed. Use the right words. You cannot just be vague about it, right? So
Yes.
setting, perception, invitation.
Patient knowledge.
Yes. That is
And
what knowledge, that all this you tell about the illness.
yes, ma'am.
Then,
Empathy, emotional venting. Yes.
yes,
Letting
allow the
the
patient to vent. Correct.
vent
So,
and
this is the
summarize.
Spike's protocol for breaking the news. Correct. So,
Yes,
as a
ma'am.
palliative care physician, if this patient comes, you'll sit down, you'll ask him what he already knows, then you give him the information after he says, okay, tell me what more to be done. So, this is all you will do. What else will you explore in this patient? So, you have talked about you have made him understand his condition. What will you do next, Sajida?
I will ask him what is his most distressing problem now.
Correct. So what
what
does bothering him? So suppose he says it's breathlessness. Okay. So what will you ask him next about breathlessness?
are you having breathlessness even at rest? I mean, which
He's on
goes,
oxygen. He's panting at 30 per minute. Will you still ask him?
no,
So how will you ask him?
um,
What
what
have you given up because of your breathlessness?
Okay.
What is it that you're not able to do because of your breathlessness? So he will say, I cannot go to the toilet, I cannot wash on my own, I cannot talk on the phone, I cannot play with my grandchildren. So many things he will come up with. How we ask patients, are you better? Is your breathlessness better? Are you coughing? Are you sleeping? That is not the point. What is it that you have stopped doing because of your breathlessness?
Okay.
Isn't it? It has completely, it's a life-changing event for him. He's not even, he's bedbound, he's housebound, he's stuck to the nasal cannula, he cannot go to the loo, he cannot go to the, take a bath on his own. So imagine his dependence level. So automatically, when you're, imagine sitting in COVID, all of us were stuck in the house, no freedom. What started happening to all of us, Priya? Dr. Priya ki? Yeah.
Anxiety, ma'am, depression,
So
anxiety.
psychosocial, very,
Yeah.
very good, right? It's
Yes, ma'am.
irritation, frustration, anger. Why me? I have not done anything wrong. I have not smoked. I have not done this. I have not done that. So all that, this man who was once going to run the house is now so totally dependent that he can't even go to the toilet on his own. So there's frustration, anger, irritation, fear of death. Correct?
Yes, ma'am.
Do we in MBBS have we even thought of all this when patient says, I am breathless? Do you even think like that? Have you all been taught to think like this? Yes.
Unfortunately not.
No, ma'am.
Yes. So, if you have seen a loved one breathless, or if you've seen a loved one in pain or constantly vomiting, you know the amount of stress which is there for the patient and for the family. So, there is so much psychosocial distress when a patient is constantly breathless every minute of the day, day after day, week after week, year after year. Correct? Can you imagine the stress levels in the house? So, here you have told the patient his condition. You have then asked him what is upsetting him the most. You asked him how his life has changed. And then you also explore. So, how will you ask this patient a question, Nitish, about psychosocial?
And we can begin with his family support and.
So, I have already told you the family support. Dr. Priya
Yeah.
noticed it right in the beginning. He has two differently abled
Yeah,
siblings.
two
He's
different
not
able.
married.
Yeah, not married.
So, that means
Whether
he has zero support.
whether he has any extended family or his neighbors who are there any sort of personnel available for his support?
So, that is one. What else?
Obviously, he has lost his job during this pandemic. So, what is his
Financially, correct?
financial status?
Yes. So, what
Whether
is
he
the
can.
question that you will ask him about psychosocial? Are you worried, anxious, scared about something? Who's
Current
your support
condition,
system? What is
how
the
he's
financial situation? Right?
what is his financial situation, how he is managing it, whether he can, is there any other way that he can avail any sort of financial help?
Correct. Correct. So these are the things that you will explore. So imagine we started with interstitial lung disease, we came to breathlessness, and now you have reached psychosocial. So it's all class. That is the multidisciplinary team of palliative care, not just respiratory. You also have to be a great communicator. You also have to know psychosocial, financial. You know how to explore the financial situation. And what else will you tell him to do? You have a patient who is breathless. You have a patient who is scared to move and he's on oxygen, which is the one thing that we doctors are again not taught in medical school. What is important? What happens to you when you fracture your hand or you have a patient who's on stroke? What is the patient sent to once the cast is removed? Or for the stroke patient to improve? What is that one word?
Physiotherapy.
Rehabilitation. Correct? Very, very important. Even patients who are chronically advanced lung diseases need to be sent for rehab because physiotherapists work on the anxiety levels by teaching them relaxation breathing. And for them, going to the toilet, eating a meal with the family, or playing with the grandchild is a marathon. So you and me train to run 20 kilometers, correct? Every day we run one, then next week two, then. So we are training our so-called normal body to run a marathon. For our patients, going to the toilet is a marathon. So you need to see to it that they are trained to do activities of daily living with much more confidence and less effort. The patient is so scared to move that he says, I will feel very breathless. I'm not moving. You have to break those barriers, explore his fears, give him the confidence, find out what's happening, and slowly build his muscle strength. So, what all have we talked about? Dr. Anita, can you just summarize what is the palliative care input in a patient with chronic respiratory disease? Dr. Anita, are you there?
Can you please
Yes,
repeat
ma'am.
the question?
Yeah, the question is simple. It's a patient of chronic advanced lung disease, in this case, an interstitial lung disease. What will you do as a palliative care physician so that the patient is feel more supported? What are all the domains of care that you will offer to this patient?
First of all, oxygen support, ma'am.
So that is physical.
Mm.
Physical.
Then psychological support, emotional.
What will you do? Whom will you refer to?
uh,
Whom do you refer to emotional?
Counseling,
Correct. Psychologists.
psychologist,
Correct. Third.
family support.
Okay, you'll speak to the family. What is that called? Caregiver support.
uh,
Isn't it? Caregivers
Yes.
also go through equal amount of trauma. Okay, what else?
Social support, ma'am. Economic.
How? So what is social support? Means whom will you refer to? You have to get practical solution.
Social workers, ma'am.
Exactly. So you involve social workers. Yes. What else? Pulmonary rehab. You'll involve physiotherapists.
Yes, sir.
Correct? So all this comes under the purview. So next time you see a patient who has chronic breathlessness due to advanced lung disease, you need to sit and explore all these. Are you coping? Is your family coping? Do you have support? Are you worried? What is it that you've stopped doing? How can we help you? What exercises are you doing? What can you do independently? This should be your history taking. Is that clear?
Yes, ma'am.
Yeah.
Yes, ma'am.
Now, another very important point I want to ask you. Now, how will you treat this patient if he comes to you as a palliative care physician? The pulmonologist has given steroids, he's giving antifibrotics, he's given the oxygen. What will you do as a palliative care physician?
We can start them on some anxiolytics.
Sorry? That is the counselor's business. Na? What is your job? So, in other words, you have a patient who is chronically breathless. How are you going to, when that patient becomes suddenly worse, acutely breathless, what are the non-pharmacological aspects of treating breathlessness? What all will you tell the patient at home? Because the minute any patient gets breathless, what do they first do? Call the casualty or call their doctor? What will you tell these patients who have incurable, progressive, chronic lung diseases? Should they keep coming to casualty? Are they going to have a solution?
There's no solution.
There is no cure. But does that
Yes.
mean we stop caring?
We
Oh.
try to offer as much support as
Yeah.
possible in
But what are the non-pharmacological things? See, you need to tell them what you have told them. There is no point coming to casualty or hospital. But you need to tell them what to do. The
Sitting in
birthright of a
proper
patient is to
position.
be comfortable. So what will you tell him to do?
Asking the patient to sit in the proper position, asking.
Positioning. So
Yes,
some
ma'am.
people like propped up, some people like bending forward, some people like right lateral. So everybody is different. So position, excellent. What else?
Hand fan, small hand fan in front of the face.
Okay, what does the battery operated hand fan do?
When the patient will have an episode of breathlessness, we can ask the patient to put it in front of the face, open the mouth and try to breathe in the air from the.
What does the fan do?
The sensation of the air coming on the face has
Yes.
been shown to improve the dyspnea.
So if
Sensational
you
dyspnea.
actually Google search handheld battery operated fan and chronic breathlessness, there's a lot of research done by just the cool air blowing in the face. There are changes in the respiratory center as documented in the MRI. So it becomes less irritable, more quiet, and therefore the respiratory rate becomes less. Excellent. So handheld fan, positioning, well ventilated room, do not crowd the patient, give the patient some loose clothes, and then you can do relaxation breathing that the physiotherapist has taught the patient. Remind the patient how to breathe slowly, take a deep breath so that there is better ventilation. Then you can also distract the patient by massage, music, pet therapy, etc. What is the one wonder drug that can be used to treat patients who are chronically breathless?
Morphine.
Morphine.
How will you start the morphine?
Um,
And how does morphine act? Yes, somebody very confidently said morphine. I'm very happy, but can you please tell me how does the morphine act? How much is the dose? What is the side effect? What is the prescription? Dr. Vijaya hasn't answered. Dr. Yamini hasn't answered. Dr. Shraddha, I think. Dr. Mohammed, anybody who wants to go. I don't want to pick on anybody.
We will start as low as possible, ma'am.
Which is how
Around
much?
1 mg, 0.5 to 1 mg.
No. How much
2.5.
tablets do you get in
5
India?
mg, ma'am.
No,
10
10.
mg.
10
You
mg,
get
10
10
mg.
mg
10
and
mg,
you
yes,
get
ma'am.
immediate release, and some cities
Yes.
you get sustained release.
Yes, ma'am.
But we usually start with 2.5 milligrams twice a day. How much? 2.5 milligrams twice a day. How does morphine act? Morphine is a narcotic.
New antagonist.
Hello?
Respiratory
It,
center depressant.
So it's a central acting medication.
Yes.
Okay, centrally acting. It acts on the respiratory center. It's a narcotic. So why is it safe in patients who are chronically breathless? Because patients are breathing at 35 and 40. So the respiratory center, it acts centrally, therefore decreases the work of breathing, improves the tidal respiration, improves the depth of breathing. And from 35, the patient starts breathing at 20, 25. So for that patient, it is very
Oh.
good. Understood?
Yes, ma'am.
So
This was
morphine
nice.
is a centrally acting drug. It is a narcotic. It acts on the respiratory center, decreases the work of breathing and the respiratory rate. So person going at 40 can start breathing at 25. Have you tried breathing at 25? So suppose you run up the stairs, like 4 flight of stairs. How do you feel at the end of it? That is of course tachypnea, but your respiratory rate is high. You know how you can't talk, you're panting. Our patients are like that all the time. Imagine if you make that particular patient little bit more comfortable. What is he going to come back and tell you? If you start the patient on morphine 2.5 milligrams 12 hourly and the patient's respiratory rate from becomes, what is he going to tell you? If your symptoms get relieved, do you thank your doctors or you curse your doctor?
Thank.
Obviously. So I have had patients who have come in the wheelchair. After starting morphine, they actually get time to wear a sari, wear earrings, wear lipstick, and walk to the OPD. So we are not able to cure the underlying condition, but we are able to improve their quality of life. And that is the whole ethos of palliative care. So low dose morphine is extremely safe in patients who are chronically breathless. So indicated patients. If you and me take morphine, we will all get addicted. But an indicated patient, careful selection of patients, those patients on optimum treatment for their breathlessness, for ILD, for COPD, for asthma, despite that, when they continue to feel breathless and when they continue to experience this distress, psychosocial, emotional, financial, all this in their mind, that is the time to start these patients on low dose morphine. Is everything clear?
Yes, ma'am.
Very weak yes, ma'am, has come from one human being.
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
So whenever you have a patient with a symptom referred to you, distressing symptom referred to you in palliative care, please explore psychosocial, emotional, financial, caregiver burden. How has life changed for him? Address these issues. By acknowledging that, oh God, it does seem very distressed, 50% of the patient's problem is solved. You know, and patient also knows that his physical condition, the anatomy of the lung, the heart, the kidney is not going to change. But you promise to improve the quality of life. Start with non-pharmacological things, simple things like you all mentioned, positioning, clothes, fan, handheld fan, all these things help them tide over the acute crisis. And the role of morphine, very, very important to read up morphine in chronic breathlessness. We are not able to change the outcome, but at least make the journey bearable for that patient. Instead of being panting all the time, the patient is able to do small, small things which gives him joy. And that is why we are all here trying to learn palliative care. Is that clear? Any questions? There's something on the chat. I have only 10 minutes left. Some Mohammed has written, yes, ma'am. Fine. Okay, so I'm going to show you another two cases. And now you have only to tell me what you're going to do. This was a lady who was 84 with dementia for 9 years. Her son lives close by, but she's mainly cared by caretakers. Suddenly, one night, she came to the casualty because she was acutely breathless, coughing away, and desaturation. So what is the diagnosis in an 84-year-old dementia of 9 years? Okay, differential.
Aspiration.
Excellent. Aspiration. What else?
Pulmonary edema.
She could still have cardiac failure. Yes. Third, she's dementia. She has not moved from her bed. So what can she have in acute breathlessness?
Pulmonary embolism.
Excellent. So she could have P. So anything could be there. So what will you do in a patient who's 84, who is demented, bedridden? What is the quality of life?
Poor.
Zero.
Poor quality of life, right? So we think her quality of life is poor. Son says, but my mother is alive. So what will you do? How will you deal with this patient and family?
We will rule out any immediately treatable causes like infection
Excellent.
or something.
Correct the correctables. Very good. Suppose it is aspiration pneumonia in a demented patient. What is the reason for aspiration in dementia?
Difficulty swallowing of food.
See, swallowing is a neurological mechanism, right? Correct?
Yes,
So
ma'am.
dementia, in advanced dementia, swallow is affected because there's total disconnect between the swallow muscles and the nerves and the sense things coming from the brain. So patients tend to aspirate. And the commonest causes of death in dementia is aspiration, sepsis due to urinary tract, or bed sores. Unless the patient has something like a heart attack, that is different. Pure dementia with no other comorbidities usually dry off these three reasons. So what would your palliative care approach be in this breathless 84-year-old with dementia? What all will you do to this patient?
For relief of breathlessness, we can give a small dose of injectable morphine. For feeding, we can insert a rice tube or.
So first you will settle the breathlessness. You will put an oxygen, you will correct the correctables, you will take an X-ray, you will do a blood gas, you will do all that, correct? All that you will do to settle the breathlessness. So first thing you give shot of morphine, or you will do antibiotics, then you'll do bronchodilators because it's a pneumonia. You treat the pneumonia. When do you give morphine? It is chronically breathless.
Yes, ma'am.
Correct?
Yes,
This
ma'am.
patient has had first episode of breathless. We don't treat all our asthmatics and COPD with morphine when they come from day one. So if it is an aspiration pneumonia, you first assess the patient, put her on oxygen, give her fever medications, give her antibiotics, give her bronchodilators, give her steroids if she's an asthmatic and the pneumonia has triggered her asthma. So there is no role for morphine in acute settings of breathlessness. Acute MI is different. Okay, and acute pain is different. Understood? Now somebody said more Riles tube. What is the logic of, is it ethically and legally and medically correct to put a Riles tube in a dementia patient who's not spoken a word, doesn't recognize, and all of you have accepted that the quality of life is zero? So what are you doing with Riles tube? You're prolonging her life or returning her to good quality life?
Ma'am, we'll take a history of dysphagia because these people have dysphagia. So in case that is there,
How
then
does a
Riles tube will-
dementia patient give dysphagia history?
And for this
The
patient, the surrogate will be
caretakers
the
might
one
be
giving
able
the
to tell.
consent.
How? How can anybody tell ki I have pain in swallowing or difficulty in swallowing in a demented patient? You can do swallow assessment. But dysphagia, how? It's a symptom, right? Dysphagia is not a diagnosis. So swallow assessment, I agree. So if the swallow assessment is suppose bad, then you'll still put a Riles tube. Your
Yes,
patient is
ma'am.
not your patient is not going to cooperate with doing any exercises to improve swallow because she's demented. She's not going to understand.
No, ma'am. We would not like to put a Riles tube until unless patient is unable to eat properly.
So therefore, it comes to in very. I want to trigger this discussion here.
Or if the
Please remember,
patient is because of poor eating is losing weight, or
what is your
you know,
significance of this 80 for you? You want her to continue to be demented for another 5 years and
No, ma'am.
survive
Ma'am,
with bed sore, with no
We have to
dignity.
take nutrition,
so
take care of the patient's nutrition,
At
even if
84,
the
so
patient
that she
is
lives for 10 more years.
We
So
can
I
just
want you
not
to
try to
all
prolong
understand
the
one
life
thing.
or hasten death.
No,
Try to maintain the
No.
quality.
So
no, the
first thing
son.
is advanced medical directives.
Yes, ma'am.
Yes.
Does the patient have an advanced medical directive? Here we are only thinking of what is in best interest for us. Is this in the best interest of the patient? Is
No, ma'am.
prolonging
No,
poor
no.
quality life in the best interest of any human being?
No.
No.
What are the principles of medical ethics?
Decision, ma'am.
Aut-
Autonomy is patient's
autonomous.
decision, whether they want to
Autonomy.
live with
This
that.
patient is demented, but if she's left an advanced medical directive, should you respect that when she was
Yes.
competent?
yes,
Yes.
Yes.
Asked for it? No, you're ready to put the Riles tube. So it has to be a process. Has she expressed a wish? I want to die without going to hospital. I want to die chalte firte. I don't want anything shoved into me. These things elder people speak. We don't listen. That's another thing. So advanced medical directive or wishes of the patient. Second is putting a Riles tube, maintaining nutrition in the best interest of our patient. It's
No.
a debate. So the next thing is the family will say, but you're starving. Does a dementia patient actually have capacity to say, I'm hungry, give me food?
No.
So all this needs to be assessed. You need to get a neurologist. You need to find out what is the state of dementia. You need to find out what are the things this patient is able to do. Satisfy to the family members the poor quality life. Keep the patient comfortable. Doesn't Riles tube feeding cause aspiration? Is Riles tube feeding free of any complications? Riles tube feeding doesn't cause aspiration?
It does.
Then, so and is Riles tube comfortable? Has any of you have a thingy put on your nose? What happens to most patients? What do?
Irritated. They want to take
If
it
they're
off.
conscious, they'll take
And
it out.
still we want to give them all.
No.
So it has to be it is not, how we all think. Whether it is A patient, B patients, every patient ka treatment is the same. How can that be? So please think of the situation. 84, demented, has not spoken a word, has poor quality life, comes to with aspiration. It's probably the best way for her to reach heaven, no? But we are not here to kill. We are not here to hasten death. The journey needs to be comfortable. Now, most hospitals, this patient will go to ICU, will have Riles tube, we worst, we'll put on NIV, then go on the ventilator, and then we will send the patient back home with dementia.
Ma'am, how do we know that when to withhold and how to withdraw? That is the question. Because
So
most of the
such
time,
patients, you know the trajectory of dementia, right? It is your onus, therefore, as a doctor, to explain to the patient and caregivers, the patient didn't become demented overnight. The patient has a journey.
yes, ma'am.
Who, as a doctor, need to recognize that this patient is losing competence. Talk to the family. Where is communication? It never happens when the sea is calm. It happens only outside ICU doors.
Hmm.
Early integration with palliative care, the difficult conversations will happen that the road ahead, you have seen more dementia than the patient and the family. So whose responsibility it is to foresee and foretell?
Ours.
Do we take up that responsibility? Never.
At times we are scared.
Immediately for emergency. That's because you're not competent in communications.
Yeah.
So you ask the patient. Spike's protocol is exactly for that. Do you want to know? If the patient doesn't want to know, then at least you've tried. Here, though, we don't try only because it's eating our time.
Madam, if we
Need to-
don't put,
Hmm.
if we don't put Ryle's tube in this patient, patient will deteriorate and deteriorate.
And then, is the patient enjoying life in dementia?
No,
Is the patient going to improve and talk back to you, walk and talk?
no, madam.
At
But
84, what do you expect? Patient to deteriorate or not? Normal 84-year-old. Isn't
Yes, they'll do it.
it will, no? Any human being is, as the patient grows old, the possibility of death is high, probability is higher. So you are not hastening death. You are allowing nature to take its course. We are not saying don't give the patient anything. There is subcutaneous hydration. Have you heard of subcutaneous hydration?
Yes, ma'am.
So you give the patient that so that the eyes, the skin, the kidney remains moist. You don't feed the patient orally because you're scared the patient can aspirate. Ryle's tube can also cause aspiration, irritation, pulling of the Ryle's tube. I've seen so many patients in, out, in, out. Is that joyful? Is that dignity? Is that respect? The argument is we are maintaining nutrition to prolong poor quality life. Does that make sense?
No.
You need to ask these questions before you do. Don't just do because that's all you have learned, taught to do. Why are we doing it? What happens if we don't do it? What are the benefits? What are the risks? See, sometimes a family will insist. That time you don't have a choice. But that is not the time to talk to the family about giving them all this speech. This should have happened 3 years ago. That this might happen, this might happen, this might happen. What do you all want to do? So my patients who have had the chat don't come to the hospital. The GP knows what to do. Patient is kept comfortable at home. Let nature take its course. So please read up medical ethics. Patient will deteriorate, patient will starve. Here the patient is not even hungry. Not even saying, we are only forcefully feeding the patient. Is that medical ethics?
No.
And in medical ethics, what are we supposed to do? We are supposed to do what is in the best interest of the patient. What do we do? Best interest of the hospital. Any
Ma'am,
of you, are
IV fluids
you
also
taught?
we should
1
not
minute.
give.
Budget suffering. We need to budget the suffering. Yes, Dr. Anita, you were saying something?
No, ma'am. For hydration, IV fluids are also not this thing we can't give.
IV is painful. When what happens when the IV comes out?
No,
Does
if
IV get infected?
patent cannula is there,
No.
shall we
If it's
give
there, you should give. But
Mm.
how will you send the patient home? Then the relatives have to get a nurse home to put the IV line. That is also cost. Subcutaneous, the relatives can learn. The whole half the country is taking insulin.
Yes.
Correct? So
Yes.
there's a lot that you need to think laterally. That's why you need to read these things. What is in the best interest of the patient? Am I doing harm? Is only prolonging life the reason you have become doctors, or you become doctors to alleviate suffering, care for your patient? We are health care professionals or health cure professionals.
Here.
Then where is the care in our medical curriculum? We only prolong life. Patient should not die in my duty. Is the first thing we announce.
Yes, ma'am.
Survival. Even if the patient is bloody in pain or breathless, but patient is alive. Is that what we should be thinking? How many of you pray in front of the Lord that keep me alive with tubes in every orifice and IV line, central line, arterial line, but keep me alive? How many of you want to live like that? Can I have a show of hands? None of you, na?
Depends on the cause, ma'am. If it is
No,
something I
but
can
you
be
tell
paid
me,
for,
Dr.
then
Abraham.
definitely.
No, you tell me very simply. Do you want to continue to live with a ventilator, with the Foley's, the tracheostomy, with a central line, arterial line? Obviously, I'm talking of an incurable progressive disease.
Yes, ma'am. If I have an MI, I hope that all these things will be done for me, ma'am. I do
Yeah,
not
correct.
say
So
it is not
I'm talking
indicated.
of an
Where
incurable
it is
progressive condition.
indicated, it
Is
should be there.
dementia equal to an MI, Dr. Abraham?
Ma'am, we don't want to, but what happens, the practical aspect is that when we are in a hospital, we are
Because
so
you don't
afraid of so many
don't
things.
ask your patients for advanced care directives. Supreme Court has said, please make living wills.
Yes, but
Not
that
when
doesn't
do you learn
happen.
to
In the
swim,
practical
Swati?
aspect, it doesn't happen. The relatives pressurize you so much, and these
No, no,
days, the
no.
way the
See,
things are,
1 minute,
doctors
Swati.
are so afraid.
No, no, no. So 1 minute, Swati. When do you talk to your patients? Only in a storm. Never when the sea is calm. Have you prepared your patients? No. If they don't know the trajectory of the disease, they will say sab kuch karo. And you will then get subjected to that sab kuch karo because you've never had a conversation saying ye karne se this is the problem. Ye karne, and still if they decide, at least you have tried. Here we don't even try. We give up before because we are scared.
In that case, the thing that palliative care should have started right from the time of diagnosis. That is very important. We should
That is
talk to
the
the
funda
family.
where MBBS doctors need to refer patients.
Yes, ma'am.
And MBBS doctors themselves need to be trained, so they only can start. And nothing like a family GP because the family trusts you.
Madam, sometimes they will tell you have taken care of a child till now, so you only decide
So,
whether
how
to
would
give.
you answer that question? I cannot decide. I can only suggest and I can help you with your support decision, whatever decision you're making, I will support you. Because in medicine, nothing is right and nothing is wrong. It is to each his own. But you at least need to try to make them understand your point of view. If they don't, it's fine. It's not a hurt in your ego. That's another problem that doctors have. If patients don't listen to you, it's a hurt in your ego. Why? Everybody is allowed to have your choice of your own, na? If they don't understand, it is their problem, not yours. Why do you take it as your personal insult? It shouldn't be. My point here is very simple. Follow medical ethics. Ask the patient what he wants if the patient is in a position to answer. Please remember, do things only in the patient's best interest, not in the interest of the hospital, your pocket, etc. Third, please don't cause extra harm. You have so many stories in the ICU where the patient is dying, but dialysis is happening. Patient is given CPR. What is the point? Have you ever, means the whole point here is having conversations early. Talk about death and dying. How many of you are comfortable to talk about death and dying? How many of you people are comfortable to talk about, tell the word, your patient is dying? What all do we say? Very serious, critical patient. Anything can happen at any time. Have you, any of you used the word death with the patient before the patient dies? Answers, please.
No, ma'am.
No,
Why?
ma'am.
Because you're not comfortable. What is the
Sometimes we
one
tell
thing
them to call the
sure?
relatives when there is no, when the
Sorry,
patient is going.
sorry.
When we know that the patient is going to go very soon, like we tell them to call the relatives when there's like a couple of
So,
days we're expecting.
so do you use the word death is my question.
Hmm?
Do you tell the patient, आपका patient मरने वाला है. Your
No, ma'am.
patient is going to die.
No,
What do you
ma'am.
say critical? In anything can happen at any time.
Ma'am, saying that that आपका patient is dying, I don't think it is correct to say that because there are few patients who may come out of
So that
the
will show
present
you in poor
emergent.
light. Is that what you're saying?
Absolutely, ma'am.
So
And
what are the, then that comes to another full topic of signs of active dying. So how do you get into this position? So simple. But if the way, if you are saying that by telling the patient dying and actually the patient feels, comes out of it and you are going to say, oh God, hide yourself in shame,
no, I will not feel ashamed, but
then
it
you
is
say,
better. I would feel that to tell the relatives that your patient is not doing well
Hmm.
and anything can happen to the patient. I would rather say that
So
instead.
the simple one word is it is uncertain, right? It is
Yes.
uncertain. The patient may die, the patient may recover. However, the chances of death is much more than recovery, which is the reason we are not doing 1, 2, 3, 4, because they will want you to prolong life. So the argument here is, are you prolonging life or delaying death? You need to answer that question. Many of the cases in the ICU, we are only delaying death.
Ma'am, it is very true of what you are saying. It sounds good amongst the doctors, but once you discuss such things with the patient's relatives,
So,
most of the
Shraddha, you
times,
need to improve communication skills. That is what we have
Ma'am,
been doing. So, since 7 years, when I started, I was hopeless in the beginning. I have
ma'am,
had patients who walked out of my room saying, this woman is only talking about death and dying. But death is the only thing sure in everybody's lives. So the funda here being death is inevitable, a bad death is avoidable. So you need to improve communication skills, and it's like narrative medicine. It's amazing how you yourself feel the difference and the confidence in how you manage to convince another human being. And yes, it is very, very important to timely interfere. You cannot speak outside the ICU door. You cannot speak 2 centimeters from the endotracheal tube. Wrongest time to talk. You will get hit. And I think I have overshot my time. But the most important thing here is please explore not just the symptom, but way beyond it. Focus on non-pharmacological, start conversations early, do what is followed by the medical ethics. Please follow. Most important thing, sit back and think, am I doing what is in the best interest of the patient? Your answers will come automatically. And this is how I talk to relatives. You think of your mother. Is this what she wants? Is this in her best interest? And are we doing harm? The relatives only will give you the answer, because they know their mother better than you. So communication is a game changer. You really need to practice that as much as you can. And it's not just in medical, it's also in your day-to-day life. How you speak to your driver, how you speak to your maid, how you speak to your mother, how you speak to your spouse, everything comes back to you. If you have arrogance, if you have attitude, life is not going to be easy. Nobody's going to sit and wait. People may be scared of you and curse you behind your back. Communication is extremely important, which is something that I cannot even begin to emphasize. You must do your communications, and you need to read about non-pharmacological management of distressing symptoms, and of course use of morphine safely in chronic breathlessness after proper evaluation. Okay, I think I'm taking time from Dr. Ravi. I'm sorry about that. I will close for now, but I'm happy if you all need a backup talk. I don't know if it's even possible in your tight schedule for talking of specific diseases like COPD and ILD, but I thought it was important for you to get a practical aspect of how to deal with patients. And there's lots that we need to talk about, like withdrawal, withholding, what are the legal aspects, is it ethical? All of that also is a purview of of a respiratory physician. But if Sunil and his team have the bandwidth to accommodate, then we can have it on another talk.
Madam, one doubt.
Yeah.
Can you please tell me once more, what is the, like, when will you really recognize when to start morphine in a chronic?
Patients who are chronically breathless, I told you the definition is, I'm sure Sunil can share the article, a patient who is on optimum medical treatment for his underlying condition, which could be COPD, ILD, CCF. If he's on maximum medications, continues to be breathless at rest or minimal activity, and that affects his psychosocial, emotional health. That is when you start low dose morphine. And you keep a clear follow-up, because if the patient is not improving, then maybe he's anxious, there are other things happening. So we are not getting the results, because you don't have, once you start, it's not that you keep continuing the morphine.
Ma'am, you said we're giving BD dosing for the morphine. Is this
You
the
start
sustained
with
release
BD.
morphine?
No, you start with 2.5 BD, review the patient with laxatives, always write the laxatives, then you give the patient 8 hourly, then 6 hourly, then 4 hourly, because we want patients to be awake and comfortable, not dope them. Correct? We want patients to be awake and enjoy the small pleasures in life. But of course, it's important to keep them comfortable. So we start with 12 hourly. Sometimes patients have nausea. We adjust the dose of the laxatives, then make it to 8 hourly, then 6 hourly, and the half-life of morphine being 4 hourly. Eventually, it's given 4 hourly. Never does it exceed the dose of 20 or 25 milligrams in a patient with chronic respiratory or cardiac diseases for breathlessness. There is no ceiling dose of morphine in pain, but there is a ceiling dose for morphine in breathlessness.
Thank you, ma'am.
Okay.
Thank you, ma'am.
And I'm happy to share articles, or if necessary, take another class, because it's important for you all to realize to look at the patient as a whole. You cannot just look at the lung and say, chalo, we'll do 1, 2, 3, 4, 5, 6. I don't even know whether it helps the patient. and if the patient wants it or not. And even for the patient to make a decision, it's important that he understands his condition.
Ma'am, requesting if it's possible really to take one more class. I have a lot of questions, a lot actually. So if it's
Sunil, can you take request of that? And over to Ravi. Sorry, Ravi, I'm eating into your time. Sunil, it's okay for me to log off?
Yeah. Thank
Okay.
you. Thank
So
you for
Nitish,
joining us.
just share Nitish my email so that if there's any burning question, I can solve it right away.
Thank you
Yeah.
so much.
Thank you.
Okay, thank you.
Bye.
Thank you, ma'am.
And now we will move on to palliative care emergencies. And we have Dr. Ravikiran with us. Dr. Ravikiran is basically an oncologist, but as of now, he is practicing as a full-time palliative care physician. So he has won many awards during his MBBS and DNB, and he has done his National Fellowship in Palliative Medicine and was the topper in 2002. And he has also done his Global Fellowship in Palliative Medicine from Pallium India, and he passed it with A+ grade. So welcome, Dr. Ravikiran, and it's over to you.
Thank you very much, sir. Am I audible?
Yeah,
And,
yeah.
and the mentor like Sunil sir, you will achieve anything, whatever you want. And I'm teaching is a one form of learning, and I'm happy to learn again by teaching you all. So welcome to the course. And can somebody share the slides, please? So without wasting much time, we'll go into the palliative care emergencies. Can somebody share the slides, sir? From
Sangeet?
Yes, sir. Yes, sir.
So many of your students have been learned the modules of palliative care. So just want to know. So in palliative care, do really emergencies does exist? How many believe that among the doctors here? So,
Yes, sir, it does exist.
Yeah, thank you. Next slide, please. I'm going to these contents. Next slide. The introduction. So any emergency case, whenever whether it is a medical or the palliative care, the primary factors which we need to consider, whether the effect, whatever we do to the patient will have the reversal of the medical condition. What is your medical judgment? What does the patient and the caregiver wants? And this treatment would have an impact on the quality of life of patient as well as the family members. As well as we do in the emergency care of 5 steps like triage, registration, treatment, re-evaluation, discharge. In palliative care emergencies, we have a 6th step, that is to follow up. Next slide, please. So regarding next slide. So regarding a case, anybody from volunteer can read the case. Anybody? Dr. Nitish, Dr. Priyanka, I don't know, 414625. Anybody who can read the case? Volunteer. Okay, Mr. X is a 26 years old male patient, was diagnosed to have PNET
Mr.
of
X, Mr. X, 26-year-old male.
Yes, please.
Yes, please go on.
And with me, and the
I think he has
vancomycin.
He has some internet problems.
Yeah,
It's
he has
possible.
PNET of D11. Thank you, Bipin. I'm continuing the question. D11L1 when he was 12 years old, and he was treated with surgery followed by the chemotherapy, and now he was 27. He was on regular follow-up, but he was evaluated for blurred vision in the left eye and diagnosed to have Ewing sarcoma with multiple skeletal mets. He underwent extended bifrontal craniotomy, transbasal approach, and followed by palliative RT. it's further progressed. We have given multiple lines of chemotherapy. But after one day, suddenly he presented to the emergency department with severe low backache, which is throbbing, excruciating, and intervening ADS. It's radiating right lower limb, associated with tingling, numbness, and difficulty to mobilize. It was diagnosed to have a spinal cord compression at D5 level. Next slide, please. So, is the history, whatever you have seen, is it sufficient to proceed further? If not, why? What should be asked? Or if it is yes, what is the next best step? I need interaction. I don't want to be like one way. Please kindly, the other doctors, do participate. So is the history taken? Is the history taken sufficient to proceed further? Anything is missed in the history or everything is fine?
Sorry, I didn't see the full of the previous screen. Is he on painkillers?
Previous slide, please. So the history was he's having severe low backache, and one certain day he presented with emergency department. It is very severe low backache, throbbing, excruciating, intervening ADS, and radiating to right lower limb, associated tingling, numbness, and difficulty to mobilize. So it was found out that he has a spinal cord compression at D5 level. So this history taking is sufficient to proceed further, or anything to be taken in this?
Bladder bowel symptoms.
Yes, exactly. Bowel bladder symptoms to be noted. He has incontinence in bowel and bladder. He has not passed urine since a day, and stools also since 3 days. Okay, so the next best step, what would you like to do to this patient? He has bowel bladder incontinence. He didn't pass the urine for more than a day. Maybe drops, right? But it's he couldn't pass.
Catheterized.
Catheterized.
Yes, catheterized, and he didn't even pass stools, and he's having in severe pain.
Suppository and analgesic.
Yes, suppositories or enema is right. Okay. Now he is in severe pain. Next slide, please. So how do you evaluate the patient? How do you like to manage the patient? Well, first go to the first two questions. How do you want to evaluate the patient? I already said it is spinal cord compression D5. If it is not, then how would you like to evaluate?
So we need to identify the sensory level, motor level, and the reflex level.
Yeah. Then so evaluation indicates the physical examination. Of course, it is a biopsy proven case. You no need to have any other biopsy from the metastatic site. Then it is always have an imaging. So what would you like to do?
To see the spinal cord, MRI spine, we advise.
Okay, for the MRI spine, you need to have serum urea creatinine. You need to transfer the patient. You should have. It should not be on Sundays. If you come and or the public holidays.
X-ray also.
Yes. So this metastatic spinal cord compression to be dealt within 48 hours. If not, then the patient can go to permanent paraplegia or paraparesis. So it should be dealt within 24 hours so that the condition can be reversed. The more the delay, the paraplegia sets in, and thereafter he may have a permanent condition of paraplegia. So as much as possible, we reduce the investigations if depending upon the condition of the patient at that point of time. There is no bowel, because the bowel bladder already sets in, so the chances of paraplegia can continue if it is further. So how do you manage the patient then?
Steroids, sir. High dose steroids.
So how much dose you want to give?
16 mg.
Okay, go on. If it is your patient, he came to you. So how do you like to manage the patient? So first of all, we go with the physical domain, the pain. So what would you like to do?
Strong opioids.
Okay. How do you initiate opioids? How do you initiate steroids? What is the dose? What is the indication? Why do you want to start
Give
steroids?
IV 1 mg morphine, then evaluate the patient after 10 minutes, and then keep escalating till the patient has pain relief.
So how much vial you get?
10 mg cover.
10 mg and also 15 mg per ml, right? So if you want to give a morphine trial IV, how would you start? You straight away give the morphine to him, or what would you do?
89. We try to find out if he's morphine opioid naive or was he on opioid before.
Okay, let us consider as an opioid naive. The pain crisis also I will deal with this case only. So both this will be done here. So would you want to do the morphine trial? So before starting a trial, we need to know the basic parameters, whether he is drowsy, what is the baseline pain score, his respiratory rate, pulse rate, we document baseline. And then we start the vial, whether it is 10 mg or 15 mg, we start with 1.5 mg. When we dilute, it becomes 1 ml equal to 1 mg. And then we start with 2, if it is a 10 mg vial, we start straight away with the 2 mg. And we check every 10 minutes based on the pain score as well as the baseline parameters like drowsiness, any side effects other than this. And then we continue till the side effects are not much sets in and pain has been lessened. Based on that, we titrate the dose, and if the patient stabilized, for example, at 10 mg IV morphine, the pain is stabilized. So you continue the patient on IV continuous infusion, and he can take orally also. There is no problem for oral intake. So how do you convert a patient on IV 10 mg IV morphine, dose stabilized, drowsiness is 2/10, pain score came to 4/10, from 10/10 to 4.
3 times the IV dose and then divided into 2.
Okay,
BD
tell me the
dose.
prescription then. 10 mg is the IV morphine dose stabilized. So what is the prescription you
15
write?
milligram BD.
Okay, so oral morphine, what is the half-life of oral morphine?
4 hours.
So BD is, I mean, it is 12 hourly, whether it is sufficient.
No, we can give for breakthrough pain also.
So how do you start if it is 10 mg morphine IV? What will be the total morphine dose for 24 hours?
$15 milligram for hourly.
It equals to how much?
Twice a day.
So 10 mg IV morphine, when is stabilized with 10 mg IV morphine, the total dose of the oral morphine is 30 mg, right?
30 mg.
So first of all, we need to convert to total oral dose 30 mg. Now divide in 4 hourly, because as you said, the half-life is 4 hours, more or less in almost of all the patients. So how do you convert this 30 mg in 4 hours?
7.5 mg.
7.5.
Fourth hourly.
The 5 mg Q4 hourly, we can divide like 6 a.m. 5 mg, 10 a.m. 5 mg, 2 p.m. 5 mg, evening 6 p.m. 5 mg, and night 10 mg. At 10 p.m. we give the double the dose, so that he won't wake up in the midnight to take for the extra dose. So this is a comfortable dosing 5 mg Q4 hourly. And as you said, we take the breakthrough pain medications. Is the opioid is only enough for this patient, for this kind of patient?
Steroids also.
Laxative to be
Steroids
Neuropathic.
also need to be given.
Steroids, somebody has said. So go on, how much and how you want to give the steroids, and why you want to give the steroid, and which steroid is preferred.
Dexamethasone will relieve the edema.
It relieves the peritumoral edema. Yeah, it also acts as neuropathic component, so that the edema, when the block over there, the edema, it reduces. So how much the dose you want to give?
mg start dose, then we'll give it as 8 mg BD or TDS for at least 2 to 3 days, and then we can start tapering.
Okay, 16 mg stat dose, 8 mg BD or TDS. Okay, if it is BD or TDS, what is the time for the steroid? Will you give it like BD 8 mg 9 a.m. 9 p.m.?
Maybe 8 and 12, or
we don't prefer steroids at night time because
night.
of the cortisol increase, and that inhibits its sleep. So if it is a BD dose, you can start morning 8 a.m. and evening before 4 or on 4 p.m. so that you won't have that cortisol effect on his sleep. So 16 mg is the standard dose. We can continue for 5 to 7 days. What we do is then we taper it slowly based on the treatment part. So along with this, yeah.
So for children, per kg, how will we?
For pediatrician, I haven't done this, but we have the kg weight basis. Only we have adolescents and the geriatric adults, young adults and geriatrics. So based on that, I have given this thing 16 mg this, but body weight के हिसाब से तो देते हैं, we give based on that, but I'm not sure of it. So along with Dexa, what you want to give to the patient?
Pantoprazole.
Yeah, any PPA will suffice. And
Laxative.
Laxative because of opioids. And
Prokinetic metoclopramide.
yes, you can give prokinetic metoclopramide. And
for the neuropathic pain also we can give.
For neuropathic also you can start depending upon the assessment day by day, which is what required. So along with this, we even give radiotherapy, palliative radiotherapy. The main indication for this is the radiation therapy because it inhibits the ongoing certain paraplegic condition along with the pharmacological therapy. So we can give in a single fraction, 800 centigrade, or we can give in 10 fractions, that is 10 days we can give. Saturday and Sundays on off, so 30 gray or 20 gray also we can give the dose according to the, depending upon the PPS, palliative performance scale of the patient or the KPS. So there is a total pain concept. So you have gone through the modules, right? What is total pain concept and how do you apply to this patient?
Physical, then psychological, psychosocial, social,
yes,
spiritual.
And spiritual. So when he was 12 years old, he was infected with the Ewing sarcoma. He was on follow-up, he has received, and now he is around 25 years old now. And the present management, what after this radiation therapy, was declared as best supportive care. He was the only child to the patient, to the family members, and is very smart, active, and is a CA by profession. He's unmarried. Anybody? So how do you like to apply the total pain concept? So based on these factors, is young, is 25 is in youth. So psychosocially, there is dependency always, like even at this point of age, he feels, he sobs that he's still dependent on the patient, on the parents. He could not even mobilize. So these things definitely have an effect on the boy, and socially now he's unemployed, he stopped working, and lot of social isolation was there because he is not able to mobilize by himself. He need a wheelchair, and 24/7 taken care by their parents. And spiritual aspects, as everybody say, why me? Why this happened to me? This was depending upon the rapport and daily basis talking, we can explore the spiritual aspect of the patient. So is that all or anything else you would like to do in this case? You managed the pain with your opioids, laxatives, catheterization, steroids you tapered, and paralysis was inhibited for the time being, and his pain is under 3/10. So is that all or anything else you would like to do in this case?
We can get a radiotherapy consult. Radiotherapy
Yeah,
consult.
radiotherapy was also given to this patient because the steroids itself doesn't manage this patient. We need to give radiation therapy concurrently with the steroids and the opioids. It's a multidisciplinary team where radiation oncologists and the palliative care physicians do exercise on this so that they go parallelly. And
Support group where he can meet people with similar problems,
excellent.
or
Yeah.
family counseling,
Yes.
where we can teach the family how to keep this person busy, and even taking care of the carer, so the patient doesn't feel very guilty about being a burden on one person. That person can probably go on a leave for 5-6 days or something and come back.
These aspects to be touched upon. Along with this, we have to do passive, as madam says, Rajam madam, that rehabilitation, right? In this also patient, we don't do active rehabilitation, but we have the passive rehabilitation, passive exercises on bed, on couch, so that the muscle wasting will not be there, and walking to stretcher, and walking aids. Along with that, we can also rehabilitation also makes the independent capacity. So counseling is also do well required because he's not 80 years old. Accepting death or accepting like best supportive care, that is, there is no disease directed therapy because he has received heavy chemotherapy and everything has been done to him, and accepting that now at this point of time, like an 80 or 90 years old, it's a bit difficult. So not at all times we achieve 100% that patient will accept what is being told by us, but it's the constant counseling should be there, which affects their mood swings. Along with the patient, even the family members do have an impact. He is the only child, and because we regularly see the patient, we talk to the caregivers as well as their friends and family members. So in this way, we need to take care of all the domains of the patient, and we need to have a regular follow-up telephonic consultations. And and now we said the patient is 30 mg total dose, 5 mg Q4 Tarly, but in due time he is taking 3 or 4 PRN doses. So how do you titrate the dose again? He's taking 3 PRN doses, that is 5 mg. He's taking 3 or 4 times per day. So how do you increase the dose? How do you titrate the dose? Anybody? He's taking 4 PRN breakthrough medication doses for the pain to stabilize, along with 30 mg. Of course, he has the co-analysis, but is being required. So how is the new prescription can be given to him?
So right now we are having 20 milligram plus 30 milligram. That comes to 50 milligram morphine being given per day. So can we start him on a longer acting?
So according to this 4 yes, you are right, 4 PRN doses, so it accounts to 50 mg total dose. So we can give 10 mg Q 4 Tarly, let him stabilize, then we can switch over to the SR medication. So SR medication can be given only to those patients who are stabilized on IR. So he's requiring 4 PRN doses. So titrate the dose with the IR. It becomes 10 mg Q 4th hourly. And if 1 or 2 PRN doses on and off and is comfortable with this medication, and then we can switch over to the SR. And we have, if it is 60, then we can go 30 mg SR BD. And along with that, we can give the IR SOS. So if
Sir, I didn't get what is IR.
Instant release. SR is the sustained release and IR is the instant release which we give to the patients in the forefront, whether it is for the dyspnea or for the pain. We always start with the instant release, and any patient stabilize with the instant release dose, then we switch over to the SR medication based on the patient comfort level. If the same patient having difficulty of constipation despite you have tried all types of laxatives, so what would you like to do? He's stabilized, is happy. The pain has come down to 3/10 with the 60 mg total dose morphine, but he has chronic constipation, difficulty in passing stools despite with laxatives, all forms of laxatives. So what would you like to do this patient?
Disinfection.
Yes, please.
Enema.
Yeah, of course, enema, but daily you
Even
can't
before
give
enema,
to the patient,
we
right?
have to do rectal examination.
Yeah, we have to do the rectal examination followed by the PC enema, high-end enema. But daily you can't do this, or every 2 days you can't do this, right?
Review with the laxatives and add.
Yeah, so in order to minimize the side effects, but pain is controlled on the opioid, we switch over to the transdermal patches, fentanyl. I think the lectures will be taken for that, so I'm skipping that one. So this for this case. Next slide, please. Next slide, please.
Just a minute, sir.
Next slide. So this is the framework when there is a spinal metastasis, norms framework which we follow in our oncology unit. So Ewing sarcoma is a radiosensitive tumor, and moreover, it is in the early before 48 hours he has presented to us. So definitely we straight away go to the radiation along with the pharmacological therapy, which prevents future paraplegic. This is the framework generally we follow in our oncology setup. Even for any metastatic spinal cord compression that due to because of lung cancer, multiple myeloma, bone cancer, breast cancer, we follow this framework based on the patient presentation, whether it is acute, like if the patient is already in the bowel bladder incontinence affecting his ADLs and numbness, tingling. So definitely it requires prior attention, and we have to post him for the radiation as soon as possible. Next slide, please. So as someone's rightly said, we need to know the motor, sensory, reflexes, everything. There's an Asia impairment scale, specifically got a spinal cord injury based on grade A, B, C, D, E. We judge, and based on this, we evaluate the severity of the condition. Next slide, please. So there are the red flag signs of spinal cord compression, the pain, which is more of mixed pain. It involves both nociceptive as well as the neuropathic pain, and motor deficits as well as sensory deficits. And always you need to rule out the bowel bladder dysfunction. It's a very late finding. Once it sets in, the chances of going to the paraplegia is very much likely. Okay, next slide, please. So what do we do in these cases? So concurrently with the oncology team, our palliative care team, unit services, therapy change modification in if it is a curative option but suddenly presented with the spinal cord compression, then there is a change of therapy. Now the intent becomes curative to palliative. There are bowel bladder issues. We need to train bowel bladder training to the patient. Discussion of anticipatory events in a stepwise manner, as rightly said, the family counseling, support therapy, and caregiver concerns need to be explored. Financial, logistics, and basic amenities to be explored and intervened. Follow-up visits to align with oncology consultation to avoid inconvenience. If there is any other chance of giving chemotherapy or any oral therapy or something, so we need to align our visitations along with them or SOS based on the condition. Next slide, please. So Mr. Y is a 60 years old known case of COPD presented to emergency department with severe breathlessness associated with productive cough without hemoptysis, pain in the right chest radiating to back, unrelieved with nebulizers and OTC analgesics. And the symptoms lasted for 1 week. On examination, he was conscious and coherent. SpO2 is 80% off without oxygen and BP 140 by 100, respiratory rate 28. There is a facial neck swelling, distended neck veins. The chest X-ray immediately revealed there is a mass in the right lung encasing the vessels and no effusion noticed. So the diagnosis was already there. It is SVCO, superior vena cava obstruction syndrome. So how do you manage the patient? Anybody? Please don't be silent. If you be silent, I think everybody has to be wake up. So participate. There are no negative scores. Sunil says right now there is no negative scores. Sir is very generous. So please participate. The way you participate in this, we would have an actual interaction. Anybody?
We have to do comprehensive pain assessment.
Okay. He's
Then
having severe SOB, shortness of breath and pain in the right chest. You do complete this thing, right? Next.
this is due to the superior vena cava obstruction. So we can start steroids. Dexamethasone 16 mg stat followed by 8 mg twice daily.
Okay.
Then for the pain, we can start morphine in boluses and then titrate according to the needs and then calculate the total dose.
So
And
last
we start
case, we started the IV morphine trial. So
Yes.
if we have to start with the oral morphine trial, how will you start? Do you wait for 10 minutes, 5 minutes? If you started with an oral morphine, for example, we don't have IV in house, we have only oral. Then how will you start giving this patient? How much
Oral
dose you want to give?
Oral morphine will wait for 1 hour
Okay.
before repeating another dose.
Any other? 1 hour. And anybody else? Why all of them are silent?
So actually for this patient, we would also like to have taken a biopsy before we start the steroids.
Yeah, you're right. But the thing is that if the patient presented with an emergency department, like in emergency condition, there are articles which says that we can forego biopsy to save the life of the patient. Because even a single dose of steroid will alter the biopsy results, but saving the patient life is much more than this. So at that point, it's like a medical dilemma, whether because if we wait for the biopsy and then it might have chances that we may lose the patient as well.
We've had patients like this in the emergency ward. Usually we look if there's any accessible nodes and we send off a biopsy from the node in the emergency itself before we give the steroids.
Yeah, before starting
I
the
think
steroids,
co-coordinator.
we have this thing. So how you start the oral morphine trial in this patient? Dexa steroid definitely will help him relieve the much of the symptoms, SVCO. but the pain does persist, and if we want to start morphine in this patient, because the morphine will act on breathlessness as well as on pain. So how would we start oral morphine?
We'll start with the low dose of 5 milligram every 30 minutes.
So for the IV trial, we wait for 10 minutes. For the oral morphine, the peak at around 30 to 45 to 40 minutes. If it is substitute, how much you will want to wait? You don't have an IV route and you don't have the oral intake, oral also blocked, can't able to swallow. And there is only the one thing which we can always have the angel route is the subcute. So how much time you want to wait for subcutaneous if you want to give the trial subcutaneous? So for subcute, we wait for 20 minutes and we start the dose titration based on that. Okay, so next slide, please. So always, next slide. Along with the pharmacotherapy, we have the radiation therapy in hand. So definitely the same, like 20 gray in 5 fractions or 10 gray, 10 fractions in 30 gray. Sometimes a single dose, single fraction of 4 gray will really help the patient burden ease the symptoms. If it is a chemosensitive, then the chemotherapy like lymphoma. Yes, please.
जी से ही बात कर लेते हैं उससे.
So based on the tumor, the chemotherapy, the chemosensitive tumor definitely do well with the chemotherapy regimens. Along with that, medical care, as already you all said, steroids, opioids will definitely help the patient, and as well as the anticoagulation measures to be taken. Anticoagulation measures to be taken, but in our setup, surgical interventions for these patients haven't been yet done, and the most of the cases being handled by radiation therapy and the pharmacological therapy. Next slide, please. So this is the algorithm you can go
बहुत
through.
लंबा पढ़ा रहे हैं, ना हो रहा हमसे अभी, मैंने छोड़ दिया.
And this algorithm can help you out how to which patients can be taken up surgically. If the chemosensitive tumor like lymphoma, small cell lung cancer, definitely they are very much chemosensitive. So thereby we can have based on this tumor sensitivity, we can go to chemo and the radiation therapy. Next slide, please. So we have some grading.
ये है तो this is cancerous only. अब ये है कि उसके 2-3 तरह के cancers हो सकते हैं. ठीक
Can
है, it's
somebody
something
mute
called,
Dr. Swati
can be
Mishra,
something
please?
called hypocellular AML.
And somebody mute
leukemia,
Dr.
hypocellular
Swati Mishra.
leukemia. It can be something called myelodysplastic syndrome.
Sangeet,
In both cases,
please mute
I think at this
Dr.
age, no
Swati.
one will say ki chemotherapy do.
Thank you. So there is a use classification. Next slide. We have Yale's University classification based on these categories, depending upon asymptomatic to fatal, life-threatening, whether we need to initiate the radiation steroid therapy, or we can wait for the biopsy to come and then decide, depending upon our clinical expertise as well as our patient profile, we can proceed further. Next slide, please. Can anybody volunteer?
somebody please read this.
A 42-year-old female with CA ovary post-op, post-CT recurrence, stage 4, presented with whole abdomen pain, distension, vomiting, constipation for 4 days, associated with early satiety with small meals, anorexia and bloating. On examination, general condition suboptimally fair, no icterus, no pallor, no edema, no cyanosis. Patient is conscious and oriented to place, person and time. Per abdomen, mild fluid but not elicited fluid thrill, tenderness in the whole abdomen, and hypoactive bowel sounds on auscultation.
So this is the, thank you very much. This is the X-ray of the patient. So what do you think it could be? Anybody? What could be the diagnosis of this patient?
Obstruction.
Obstruction, because there are 8 fluid levels and there is a dilated bowel loops. Definitely it's a obstruction. My question is the history is enough or you want to ask anything else? Before going to management, is there anything you want to ask? Is there anything I missed?
Is it only constipation or is there obstipation, sir?
Constipation.
We need to ask medications.
Okay, then. So whenever a patient presented with constipation, you always used to ask, the bladder condition also. Okay, both you need to know whether she's passing urine or not along with, because constipation also does an effect on the bladder habits. So always bowel and bladder need to be taken care of. So how do you manage this patient? Anybody? Of course, pharmacologically conservative management at first, surgically, depending upon the surgeon's perspective, whether the case like is it end of life care or there is an active manage in the middle of the active management that this presented, depending upon that we take to the higher level of intervention. So preliminary we do the conservative management. So how do you manage this patient?
We have to keep the patient nil orally.
Okay.
Start IV fluids, antibiotics.
Okay.
And wait for, probably if it is a partial obstruction, sometimes it can resolve on its own by such measures. Otherwise, surgical intervention is required.
So if surgically it's an end of life care patient, surgeon's perspective is like intervening surgically is not feasible. So what would you like to do? Let us assume
You
it's
can
a
start
malignant
steroids.
Yeah, so the first thing which we do, empty the contents of the bowel which is obstructed. So we do the NG tube insertion, right, for aspiration. And then we start with our basic labs, as you said, steroids. We start, how much dose you want to give in this patient? And how many days you want to give steroids? Only steroids or anything else you want to? Next slide, please. So the management has always assured to the patient and family that we are going to do the best to relieve her symptom as much as possible. Of course, we have done the X-ray erect abdomen. We have the basic labs, NG tube for aspiration, medications, and always correct the correctable. If there is an hypokalemia, there could be having the paralytic ileus, hypomagnesemia. So we need to correct the correctable along with the present condition. Next slide, please. So what medications you want to give, what you want to avoid, what are the care of the patient and caregivers you want to emphasize? So what medications you want to give to the patient pharmacologically? We have done the NG tube insertion, we have charting, input, output charting, everything. You asked the nil per oral. So you don't, so we no need to keep the patient 24 hours nil per oral. We can wet the lips, mouth, or we can even gargle the water so that she can have that sensation in the mouth, otherwise it will lands up in dryness. So what medications you want to give? One is the steroid. Somebody is told how much dose, frequency, and how many days you want to continue.
20. ಜಾಸ್ತಿ ಫರಕ್ ಬೀಳಲ್ಲ ನಿನಗೆ ಅವಾಗ ಡಿಸೈಡ್ ಮಾಡಿ
So steroid 12 to 16 mg IV OD, which 5 days. If it is not working for then we have to stop it. If it is having no effect on the patient or there is no improvement in the condition, then we should not continue if there is no improvement. If it is improvement, then we taper the dose slowly. So 12 to 16 mg will help the peritumoral effect, the edema or the mass effect could be reduced. And is constipation, so we give high-end enema with the 16G catheter. We give high-end enema. Suppositories may not work sometimes, so high-end enema is must. And the patient history says vomiting. So what pharmacologically you want to give? Which antiemetic you want to give in this patient of choice?
Metoclopramide we have to avoid.
Prokinetic.
So somebody said the partial obstruction, right? If it is a partial obstruction, metoclopramide can be given in this patient. So let us assume if it is a complete bowel obstruction. So what you want to give?
Ondansetron.
Ondansetron, if it
And
is a complete
steroid.
bowel obstruction, it add-ons to the constipation.
And already started, that itself will take care. Steroid. We've already
Steroid,
given.
if steroid acts as an antiemetic as well, but it may not completely make the patient deprive of the emesis. Because the NG tube insertion is there and is nil per oral, she may not have the sensation. But if you want to give antiemetic of choice in this patient, you still feel nausea, still feels emesis,
Iosine can be tried.
Iosine butyl bromide can be given to reduce the secretions. So how much dose you want to give? And also helps in the pain management, iosine butyl bromide, right? So how much
Yes.
dose?
I'm not sure of the dose. 10 mg probably.
Frequency you have always have to start with the
10
frequency.
mg fourth hourly.
Yeah, 10 mg 4 to 8 hourly can be given, or the continuous maximum 120 mg in 24 hours. In continuous infusion you can give. And what else you can give for pain management? Abdomen pain, iosine can take care of pain as well as the secretion, anti-secretory. Then if still having pain, severe pain, then
So we can try fentanyl patches.
Always any SR medication or the transdermal patch can be applied only if the patient is in stable dose.
Okay.
So if you don't know the baseline dose, the patch can't be given to the patient, and the patch works only after 12 hours. Right? So for the first 12 hours, she will be in the pain, and the medication of transdermal fentanyl will release after 12 hours. The action starts after 12 hours. So what would you like to give? Instantly, so that in severe pain, if it is a mild, moderate, I think iosine butyl bromide steroid will take care of. If it is severe pain, despite with these two medications also, patient has still pain, we can start IV morphine, opioids. So it will help. Either you can give fentanyl continuous infusion opioid, or if you don't have fentanyl in house, you can have the IV morphine subcute or the IV. Every 4th hourly we can start IV morphine. right? So nobody is in accordance with that. We can start opioid, right? Morphine in this patient. So we have started the patient with hyoscine butyl bromide, steroids, of course, the basic labs correction, as well as the IV morphine. And for the anti-secretory, we can also start ranitidine, so that it also acts as anti-secretory, 150 to 300 mg per day. And thereby we taper slowly based on the condition of the profile, patient profile, right? So in obstruction, complete bowel obstruction, we avoid metoclopramide because it increases peristalsis movement. In obstruction, it's like a stone, and the peristalsis will hit to the stone. It adds to the pain to the patient. It won't actually help. In partial obstruction, we can definitely give the metoclopramide, definitely. And antiemetic of choice, nobody told me that one. For obstruction, intestinal obstruction, gastric outlet obstruction, what could be the best antiemetic of choice? So have you heard of haloperidol? Anybody heard about haloperidol?
Yeah, while reading the module,
Yeah,
haloperidol.
so haloperidol is an antipsychotic at higher doses. At lower doses, it wonderfully acts for delirium as well as for the emesis in obstruction, because it doesn't have any effect on the peristalsis movements, and it acts as excellent antiemetic of choice. In complete obstruction, we can start with 0.5 mg, and we can give continuous infusion maximum of 5 mg in 24 hours. Okay, next slide, please. Metabolic emergency. Anybody can read this for me?
Mrs. Z is a 48-year-old woman, was given a diagnosis of infiltrating ductal breast carcinoma, T2N1M0 grade 1, positive for estrogen receptors, progesterone receptors, and human epidermal receptors to HER2 new status, with 3 by 31 positive nodes. Treatment at that time involved left lumpectomy with axillary node dissection, followed by chemotherapy and radiotherapy. 13 years later, she was given a diagnosis of breast cancer recurrence with liver mets that were positive for estrogen receptors and HER2 new status, and negative for progesterone receptors based on a core biopsy. Other than the liver mets, computed tomography of the brain, chest, abdomen, and pelvis showed no other sites of distant metastasis, including the visualized skeletal system. A bone scan showed several foci of abnormal radiotracer accumulation, consistent with degenerative changes as opposed to metastatic disease. She was presented with non-specific symptoms such as anorexia, nausea, vomiting, polyuria, dehydration, abdominal pain, weight loss, fatigue, muscle weakness, irritability, and lethargy.
Can anybody spot the diagnosis or the provisional diagnosis for this patient?
UTI.
She's in metabolic acidosis.
Okay. And what more differential diagnosis? Her ABG is normal. What would you like to
With
investigate on this?
probably hepatitis.
Is it Edisonian fracture?
Pardon me, I can't hear you. So how do you want like to approach this patient? Next slide, please.
I mean, could it be pituitary apoplexy kind of?
Okay. Any other commonly seen in oncological patients? It is a very interesting case. The thing is that bone scan showed no visual uptake. But when we evaluated the basic labs, she's having severe hypercalcemia. So next slide, please. So when we even with these are rare cases in oncology in breast cancer where there is no bone uptake or there is no bone metastasis. still the patient have the hypercalcemia unrelated to the bone mets. So this is due to the PTH related peptide protein that humoral immunity, where they have severe hypercalcemia sort of. So how do you work up and how do you manage the patient? So we have the basic labs, the hypercalcemia, and what more you want to work up in this patient and how do you manage the patient? It's hypercalcemia of malignancy. Diagnosis. Next slide, please. So it's an algorithm. How do you manage of hypercalcemia? We know the basic mild, moderate, and severe based on the severity of the calcium. We initially we give the normal saline intravenous normal saline, and based on that calcitonin, if it is phosphate is also increased, we give phosphate binders, we give calcitonin, and whereas the furosemide if not in renal impairment, and we give bisphosphonates. Next slide, please. So these are the normal doses which you can go through it. Calcitonin, I just want to add, it is a very short acting. So it lasts for only 48 hours even after you increase the dose also. So definitely it should be accompanied with the saline at the rate of 300 ml per hour. Along with that, we can start with the zoledronic acid, 4 mg IV over 15 minutes. So this is the drug of choice for malignancy associated hypercalcemia, but should be taken care of with the CKD levels. Next slide, please. So there is some dose modification. How do, based on the creatinine clearance, the standard dose is 4 mg for everybody. Based on the creatinine clearance, we reduce the dose. If it is less than 30 ml per minute, we completely avoid zoledronic acid. Then which medication is better in such cases? Anybody?
Denosumab.
Yeah, absolutely right. Next slide, please. So these are the basic differences between zoledronic acid and denosumab. Denosumab subcutaneous, so there is no problem with the IV route and this thing. Even if there is no IV route, we can subcutaneously save, and it is safer in renal insufficiency as well. And there is a major delay of skeletal related events. So the span of recurrence of skeletal related events will be more compared to zoledronic acid. The thing is that it has moderate risk of hypocalcemia compared to zoledronic acid, and also moderate risk of osteonecrosis of jaw. Next slide, please. And of course, denosumab is costly. So the take-home points is always
The
take.
other oral bisphosphonates,
We can
ibendronate
give
is a
ibandronic
bit safer
acid.
than
We can give
zoledronic acid.
Yeah, we can give ibandronic acid. But the thing, the articles and the research work, the zoledronic acid is much more superior than any other bisphosphonates, the primary or the secondary. The zoledronic acid much proven beneficial compared to any other. And because of the renal insufficiency, denosumab has come into the picture, which has costly compared to zoledronic acid. But ibandronic acid can also be given, but more or less it has been faded out. But at times we use, not much in frequency. But if based on the creatinine clearance, we reduce the dose of zoledronic acid accordingly. It has much superior efficacy compared to others. So the take-home points is always treat the symptom. You treat the person, not the patient and family as a whole. And you always correct the correctable. What Rajam madam said, always correct the correctable. You have to know whether if the SOB is due to effusion, you need to tap it. If it is obstruction, you have to relieve the obstruction with the conservative management. So if it is the hypokalemia or hypercalcemia, you need to correct those things if they add on to the constipation. Next slide, please. So the spectrum of care in palliative medicine is always not just only the physical domain. We have the advanced care planning, what ma'am already introduced, the goals of care, decision making, the living will, the directives, the education to the caregiver, counseling, and of course, bereavement care. Next slide, please. So you already know it's palliative care is not an EOLC and it's not always opioids prescription. and it is delivered to all living beings, not limited to oncology or non-cancer. Even a frail old people too need palliative care. Anybody with a compassion and willingness to think outside the box, palliative care can be delivered by any individual, just like the CPR. It doesn't need any degrees to do CPR. Even a layman or anybody can do CPR or the chest compressions, right? The similar way, palliative care is also being given to anybody by anyone. Next slide, please. So there are some of my references. Next slide. Next slide, please. So before concluding, I just want what Dr. Patch Adams, American physician and social activist, said: you treat a disease, you win, you lose. You treat a person, I guarantee you, you will win no matter what the outcome is. So the palliative care is always an amalgam of compassion with practical wisdom. You need to know which things to be done in a right way. You need to judge which is better to the patient, to the family member, whether are we escalating the therapy or this therapy really helps the patient and the caregiver. It's all through experience and to expertise, and case to case it varies depending upon what the patient and the caregiver wants and what resources we do have. We can't just simply write and say that take this cinema at home or refer to hospice care. We need to know where if they are remotely located, there will be no hospice care at all. So you need to take care of before you deliver medicine, prescription, or a suggestion. So to know all these things, you need to have a much rapport with the patient, caregivers. It's not at the end of the active treatment that patient visit us. It's concurrently or prior to the mainstream line disease-directed therapy. The patient should, the caregivers and the patient should reach to us. And it is a multidisciplinary team, not a one-man show. So everybody needs counselors, nutritionists, rehabilitation team, the primary physicians on board. So everybody should collectively act for patient-centric care. Thank you.
Thank you, Dr. Ravi. That was actually you talked about the practical aspects. So thank you very much for spending this time with us. And thank you everybody for joining us. Sangeet, it's over to you.
Okay, thank you, sir. Thank you, Dr. Ravi, for the wonderful presentation and clearing all the doubts of the participants. Thank you, Dr. Sunil Kumar, for facilitating the sessions. Thank you all for joining the sessions and making it an interactive sessions. Thank you. Let's see you in the next section. Bye.
Thank you.